In this presentation, I'll be covering the current clinical utility of MRI in localized prostate cancer and touch on multimodality imaging. I have no disclosures. Multiple multi-center trials have evaluated the performance of multiparametric MRI in the setting of biopsy-naive men at increased risk of prostate cancer. They have consistently shown that we can avoid biopsy in roughly a quarter to a third of men while reducing clinically insignificant cancer detection. They have also shown that the sensitivity of MR is not perfect compared to systematic biopsy, and that we can miss between 3 and 11% of cancers, at least in these trials, and that the increase in clinically significant cancer detection rate varies across trials. For this reason, we do need to consider some sort of follow-up strategy and safety net for patients who do avoid biopsy with negative MR. As a result of these trials, multiple jurisdictions are now recommending MRI prior to biopsy. This is not a universal acceptance, but we are seeing growing traction in this particular indication. If this is to happen, there are multiple qualifying statements that must be kept in mind for practitioners. Most importantly, 8 to 24% of patients with clinically significant prostate cancer may be missed by MR, and patients should be made aware of the risks and benefits of biopsy avoidance. MR should only be performed if there is high-quality interpretation and operators with experience are performing targeted biopsies. Biparametric MR, that is the use of MR without contrast enhancement, can be done but should be done with caution in centers with experience and quality assurance in place. One has the option of performing targeted biopsy alone or targeted and systematic biopsy together. Many people consider targeted biopsy and systematic biopsy things that should be done together in patients who have never had a biopsy before and have a targetable lesion. This still allows for an overall reduction in biopsies in those who are MR negative, with only an 8% increase in clinically insignificant prostate cancer detection while achieving a 5% increase in clinically significant prostate cancer detection. This also allows for assessment of overall tumor burden in what is mostly a multifocal disease, as well as assessment for potential focal therapy, and avoids biases in whole gland Gleason scoring. Quality assurance is another vital issue that needs to be addressed, and progress is being made. One can divide quality assessment and quality assurance into two major categories. One is a technical form of quality assurance where the MRI must be performed up to a certain quality, and scoring schemes are being developed and tested for this, such as PI-QUAL. These are not in place and have not been fully validated as yet. There is also a need for reader qualification, and this will likely happen across jurisdictions in slightly different ways, but it is a recognized unmet need and progress is being made. Certainly, this type of quality assurance and qualification of readers within institutions can be performed now and is important. We mustn't forget that the targeted biopsy operator, as well as the pathologist, must be part of this quality assurance assessment. The landscape for patients with prior negative biopsy remains essentially unchanged, so I won't go through it. Suffice it to say that most practitioners now recognize that patients with elevated risk with prior negative biopsy can benefit from MR, and this is typically funded by providers across most jurisdictions. As we see increased adoption, there are unmet needs in the flow of patients through initial assessment and follow-up. One of them is for risk nomograms or risk calculators and models that include MRI data. For example, when is it appropriate to perform an MR? Can we make assessments that help us use MR effectively and not overutilize it and potentially do harm? Another example, in patients who have equivocal or negative MR reads but are at high risk, how do we decide how to proceed with those patients? And how do we make that assessment based on prior information? In addition, there needs to be some standardization of the targeting approaches and the decision of the use of systematic plus targeted biopsies combined, as well as some standardization of the number of minimum samples that should be obtained per target. Most people agree that more than 2 samples should be taken for the index lesion to ensure that Gleason 4 components or higher are not missed in what is a heterogeneous disease. In Toronto, we performed an assessment of over 800 patients where we looked at their PSA density prior to MR to see if we could find a threshold where the utility of MR was minimal. In patients with PSA densities greater than 0.078, what we showed was that the number of positive MRs was extremely low and that we could reduce MR utilization by 25% by not performing MR if PSA density was less than 0.078. So in this graph on your right, the goal is to minimize the amount of orange, maximize the amount of red, and you can see that at PSA densities around 0.07 and 0.08, we can achieve that while missing less than 1% of clinically significant cancers. So this is a very simple approach, but an example of the type of approaches that are needed. Certainly, fluidic biomarkers other than PSA can be used. And of course, this approach requires assessment of prostate volume prior to MR, which would involve an in-office ultrasound, for example, a relatively low-cost exam. Another scenario that is important and that we are encountering more and more frequently is the patient with an MR Visible Gleason 6 focus. So here we have a study again performed at our institution in over 400 men with a median follow-up close to 4 years, showing that if you have an MR Visible Gleason 6 lesion, seen in this red Kaplan-Meier plot, the biopsy upgrade-free survival is worse and the treatment-free survival is worse with hazard ratios of about 2. And in those patients that have radical prostatectomy with MR visible lesions, the presence of clinically significant disease or aggressive disease has a hazard ratio over 4. This suggests that patients who have MR visible lesions and Gleason 6 disease may need different surveillance strategies than those with MR invisible Gleason 6 disease. Of course, this is a retrospective study and has biases, and we need more prospective assessment, but this does suggest that MR information and visibility is vitally important in Gleason 6 disease. We also need more biologic studies in this area. Of course, risk models are often developed in the context of regional populations, and it's important that they be validated across multiple centers and different populations. One way to do this is to perform validation studies with calibration. There are a couple of issues with current risk models in that the risk thresholds in which they perform best are relatively high. This is an example of a study that we did in Toronto, looking at established risk models and looking at reduction in biopsies per 1,000 patients, but at relatively low risk thresholds in the order of 0.1 to 0.2. And when we do this, what we see is that even after calibration, a lot of the published risk models that incorporate MR data don't perform so well, as seen by the dotted lines here. However, strategies that are relatively simple that incorporate PSA density and PIRADS, represented by the red and purple lines here, can perform well. Of course, further validation is needed here, but this certainly suggests that MR information is vitally important in some approaches that can be relatively simple, do hold up at low risk thresholds that are clinically applicable. When talking about multimodality imaging, certainly the combination of MR and PSMA PET is of interest. Multiple studies, and this one in particular, which looked at over 200 patients and radical prostatectomy, have shown concordance between MR findings, particularly index lesions, and localization with PSMA PET-CT. I think this immediately opens the opportunity for using CT PET for cancer localization in those patients who have a contraindication to MR or a technical issue with MR, such as hip prostheses or cardiac pacemakers, etc. In addition, there may be added value, but I think the jury is still out on equivocal MR cases. We have not had great success at our institution as yet in that scenario and are still evaluating it, but it is something that will likely be an adjunctive test to multiparametric MR in the future. So in summary, MR is appropriate for biopsy-naive patients in increasing number of jurisdictions, but an optimal utilization strategy has yet to be established. Survival and recurrence impact have not been established, and quality control frameworks are being developed. A need to include biopsy operators and pathologists. Validation of risk stratification models is important. These need to include MR data, and integration with fluidic and pathologic biomarkers, which have different availabilities in different healthcare systems, also needs to be performed. Well, thank you very much for your attention.